All right, I think we're going to go ahead and get started. Good morning, everyone. Thanks for being here so bright and early for our first pharmacy discipline group session of this year's NACFC. Our topic this morning is Cannonball, topics making a big splash in CF ambulatory care. I'm Hillary Vogt. I am, as of a couple months ago, one of the pediatric pharmacists at Riley Hospital for Children and Indiana University Health. But for the prior 5 years, I was the adult outpatient CF pharmacist at IU as well. My session chair today is Kelsey Campbell. She is a certified pharmacy technician in the CF Ambulatory Care Clinic at SSM Health Cardinal Glennon Children's Hospital in St. Louis, Missouri. Before we get started today, I actually am going to invite up Dave Young to do a little special announcement too.
Oh my gosh, these are always too tall for me, but welcome everybody. My name's Dave Young. I'm the Adult Center Director at the University of Utah, and just want to take a quick minute to recognize somebody in our community who is still loosely connected to the community, but has taken a different job. Jeff Zobel, for those that you don't know. Where is Jeff? Where is he hiding? Oh, he's hiding out over there. So Jeff is a giant in the world of CF. I had the privilege of, I've worked with Jeff almost my entire career, his entire career. This is a guy that I've had the privilege of being my practice partner as a pediatric pharmacist at our center, and I was the adult center director, the adult pharmacist there. And Jeff came to us in 2006. I worked with him for the past 17 years, and actually worked to him before that. When I was the adult pharmacist at our center, I got this phone call from a fourth-year pharmacy student from University of Arizona. He's like, "Tell me about this continuous infusion stuff that you guys are doing, and what is it, and how to do it, and what fourth-year pharmacy student does that?" And then he decides to do a residency up at Primary Children's Hospital, and then I was blessed enough to have him stay on with us over the course of that time. For those that you don't know, Jeff's helped change the landscape of what does it mean to be a CF pharmacist in this country, and help lead that effort. I've been on a co-author with him on 26 publications, and in this summer, basically, he took a job down here in Tucson. He's a peds pharmacist down at the Pediatric Center in Tucson, and I was blessed enough to spend a couple days with him there. But that's not why I'm up here. I'm up here because I want to thank him from us collectively as a pharmacy community for all that he's done. It's hard to quantify. I don't have a slide or anything, but for those that you know him, the guy is he's just the best, and he loves his patients. When you think of the word advocacy and CF pharmacy, that is what it looks like. Jeff has fought lots of fights for us in the background on access, adherence, and all kinds of other things like this that you may not have seen, spent hours and hours on end. So wish him the best in his new role. But we wanted to give him an award here. It's unofficial, but it's an award from the pharmacy community. So Jeff, if you'd come up. It's a pair of lungs if you can't see. Really cool pair of lungs. Oh, cool.
Very good.
That is the first time in history I've been taller than Jeff, so I took full advantage of it. But sorry for disrupting the, but if you get a chance, stop by, give the guy a shake, a hug, whatever. I miss him dearly every day. His patients miss him dearly every day. We have transition patients coming over, and they have really cool stories to talk about Jeff. So for those, I mean, you guys that are in this room, you know you know the impact that you have, and so keep it up. Keep up the work, and that's what motivates me to show up every day as patients. So with that, we'll get your session going. So thank you.
All right. So today we are going to be discussing new treatment recommendations for CFRD and CF-related liver disease, describe opportunities for expansion of clinical services performed by pharmacy technicians, and create a plan to improve access to CF medications by overcoming insurance and financial barriers. Our quick agenda here, we're going to start off with some education committee updates, and then we'll go through CFRD, liver disease, and end with 2 presentations by our pharmacy technicians who are going to talk about expansion of pharmacy services and specialty pharmacy services. So I will hand it over to Kelsey to introduce our first speaker.
Thank you. Yes, I would like to introduce our first speaker today, Dr. Brittany Wright, who is the clinical pharmacy specialist within the pediatric and adult pulmonary clinics at the University of Iowa Hospitals and Clinic. She also maintains an adjunct assistant professor appointment at the University of Iowa College of Pharmacy. After obtaining her Doctor of Pharmacy degree, Brittany completed both PGY1 and PGY2 ambulatory care residency training programs. She holds board certification in ambulatory care and is involved in both didactic and experiential teaching, as well as several committees within her institution and the Cystic Fibrosis Foundation. Brittany's research interests include cystic fibrosis, medication adherence and access trends, implementation of pharmacy services, interprofessional collaboration, and quality improvement. So I'm going to turn it over to Dr. Wright, who will be sharing some education committee updates.
Awesome. Thanks, Kelsey. Congratulations, Jeff, and thanks for being one of the many mentors in the room that I've had over the past several years. Second, I will tell you all now, I'm going to avoid any more corny sports puns. I used all of those up during the session yesterday. So I just want to take a couple minutes to talk about the Education Committee. So who we are, you can see here that we're a group of multidisciplinary team members, both from pediatric and adult. This committee is formed on an application process. It's a 3-year term, so I'm lucky to be in the first of my 3 terms. Essentially, the application looks at your experience with CF, experience with creating and reviewing education documents, and then certainly if you have ideas to develop more. These applications are shared via the listserv, email, and just kind of word of mouth within our group. Here's a picture from last year's NACFC Education Committee meeting, and then I've listed just all of the committee members now. So what do? We review all the education materials that are submitted for approval. We look for accuracy, applicability for centers across the country, and then making sure it meets appropriate reading levels, which is 8th grade. Materials in the resource guide are routinely reviewed to ensure they're still available and applicable. And so I think that this is especially important now when we're in the post-modulator phase, that even myself, I've come across a lot of documents that maybe don't apply as much. And so we're really trying to edit those and make sure they're most useful for our centers. And then lastly, we review educational abstracts for the meeting. Since last year this time, here's an example of some of the new materials available. So the CF-related diabetes manual, as well as we routinely review Beacon quizzes, as well as CF Rise material. How to get to this information, and so I actually sent this out last week on the listserv as well. So if anyone is not on the listserv, please let us know so we can get you added. You can also find this on the CFF website through the resource library. If you ever need assistance of any sort, certainly feel free to reach out to me, or we have the contact information here. Information can be printed, but if you would like to have professionally printed instead of just from your clinic, you can also order via the screenshots included here. And certainly if you have any questions or have ideas for more topics, please feel free to let us know. We routinely send out assessment surveys for what kind of information you're looking to see. If you're perusing this tonight because you are curious what Brittany was talking about up here, and if you see something that really is out of date or inaccurate, please let us know. There are a lot of documents, and it's really a big undertaking to make sure that those are all up to date. So if you find something, please let us know. If you find something helpful to one of your patients, maybe bring that to the attention of your the pharmacy group or your center as well. And then if you have taken the time to make a really cool handout that your patients have found to be helpful, please consider submitting that to the education committee. I know on the listserv we've had a lot of handouts that have just kind of circulated, and those would be really good to formalize. So with that, thank you very much.
I also wanted to mention that between our next speakers, we'll do the Q&A portion after each individual speaker. So please put your questions in the NACFC app, or if you would like, you can come up to the mic right in the middle here. The session is recorded, so please come up and do them in the mic so that they can be heard by the audience when it's presented later. So.
Okay, and I would like to introduce our next speaker, Dr. Katie Kaput, who is an assistant professor of clinical medicine at the University of Utah in the Division of Endocrinology, Diabetes, and Metabolism. Her career focus and interests include cystic fibrosis-related endocrine disorders, diabetes technologies, and diabetes kidney disease. She is currently a participant in the CF Envision training program for emerging leaders in CF endocrinology. She lives in Salt Lake City, Utah, with her partner, Roman, and her dog, Copper. Outside of work, she enjoys hiking, skiing, and rock climbing. I will now turn it over to Dr. Kaput, who will discuss what's next for adults with cystic fibrosis-related diabetes.
Welcome. I'm actually with Dave at Utah, so thank you for everything you've taught me so far. This is actually my first NACFC meeting, so prior to this I've spent a lot of time in adult endocrinology, and now I'm transitioning over to a career in CF, so thanks for the invite. So today we're going to be talking about what's next for adults with cystic fibrosis-related diabetes, and is that advanced diabetes technology, incretin therapy, or transplant. These are my disclosures. In this presentation, we'll provide a brief overview of cystic fibrosis-related diabetes, including the prevalence, pathophysiology, and its impact on the adult population. We'll review recommendations for current management of CFRD, including CGM, insulin pumps, and automated insulin delivery systems, and how diabetes technology can improve CFRD management. We'll also briefly touch on incretins in CFRD and their evidence in cystic fibrosis-related diabetes. And lastly, we'll discuss transplant options. So cystic fibrosis-related diabetes is the most common endocrine complication of CF, with prevalence from the registry data suggesting 20% of adolescents having diabetes and 40 to 50% of adults. It shares features of type 1 and type 2 diabetes, but is distinct. And most importantly, different than other types of diabetes, it impacts nutritional status, lung function, and mortality. So the pathophysiology of CFRD is complex and is still being investigated, with the primary defect being insulin insufficiency or decreased insulin production, either due to beta cell dysfunction or beta cell loss. Insulin resistance plays a small role, particularly during active infection or in the setting of steroids. And alpha cell dysfunction is also apparent with impaired glucagon suppression. And lastly, pancreatic fat malabsorption leads to further or reduced signaling of incretins and results in further cell beta dysfunction. So what are our current treatments? Right now we have diet and lifestyle, and there's an emphasis on diet quality and also a close evaluation with a nutritionist. We also, since 2019 roughly, we have CTFR modulators with most data on potentiators in particular. However, data on glycemic control is mixed. So insulin remains the gold standard, and it's actually the only therapeutic shown to improve nutritional status for persons with CF, lung function, and mortality. However, insulin has many advantages and disadvantages. So insulin is anabolic, so it leads to weight gain and also increases survival. But relatively few people monitor their blood sugars, and close monitoring of blood sugars is absolutely necessary for intensive insulin therapy. Many struggle also to balance the demands of diabetes with other healthcare obligations, finding 3 to 4 shots per day to be quite demanding. So what about advanced diabetes technologies? Can we use these technologies to reduce this burden to patient management and improve their care? So diabetes technology is essentially a term that's any hardware device or software that people with diabetes use to manage their condition. CGMs, or continuous glucose monitors, are minimally invasive devices that are used and inserted in the subcutaneous space in place of fingerstick blood sugars, and they can read out blood sugar values every 5 to 15 minutes. They're widely used for diabetes and have been associated with improvements in glycemic control, health-related quality of life, and treatment satisfaction in other diabetes populations. Insulin pumps, by contrast, are a device used to deliver continuous and precise amounts of insulin, and it's an alternative to injections. They may offer more flexibility in insulin delivery compared to injections, and they're programmed to match an individual's daily routines and activity levels. Currently, there are 2 main types of insulin pumps available commercially. So there's conventional or sensor augmented. So the manual insulin pump, or also called the conventional insulin pump, is essentially user controlled. So it delivers insulin based on user inputs. So a provider or a pharmacist or an educator must calculate and input the basal rates, bolus doses for meals, and the correction doses. It is not integrated with CGM. So users need to wear separate CGM or perform fingerstick checks to input the values into the device. There is still requirement for mealtime boluses, and basal adjustments are needed. So users have to reprogram those rates throughout the day based on their needs, their activity, and their other lifestyle factors. It may offer independence because it offers a little more flexibility in terms of activity and other daily activity or daily lifestyle factors, but there's a steep learning curve. So what about automated insulin delivery systems? These are also known as closed-loop systems, sensor-augmented pumps, or artificial pancreas systems. These are designed for automation. So they base delivery on real-time data from the CGM, and they use an algorithm to make automatic adjustments to the insulin delivery based on basal rate and correction boluses. They include CGM, so the CGMs are directly integrated into the device, and there's constant measurement of blood sugar levels throughout the day, and that allows the system to rapidly respond to those blood sugar levels and adjust the insulin. The target range on these systems is either preset by the device itself or preset by the patient. And then the system strives to keep that blood sugar at the preset range targeted. The main thing that I think is best for patients in general is that this allows for reduced user intervention. And so users still need to manage factors like bolusing for meals, but the system handles most of the other factors. So these are all the available systems in 2023. On the right side of the screen is conventional insulin pumps, and on the left side of the screen is the sensor-augmented or automated insulin delivery systems. Those that are bolded are actually pharmacy benefits. So those are things that we would actually ask pharmacy to order, and the patient could just pick up like a usual prescription. Those that are unbolded are actually device benefits, and those need to go through DME companies. So what are the recommendations for continuous glucose monitors in our population? The International Consensus on Diabetes Care recommends CGM for all patients with intensive insulin therapy with 3 to 4 injections not meeting glycemic goals. Despite this, in our patient population, there was a survey sent out, and there's very positive perceptions with CGM use, but it's discontinued almost 20% of the time, and that's mostly due to cost and increased worry about blood sugar levels. So if we're going to implement this in our clinics, we need to think about workflow, cost decisions, and data management. what about recommendations for insulin pump in CFRD? Current expert opinion and guidance on insulin pump suggests that compared to multiple daily injections, insulin pumps may actually more closely mimic physiologic insulin secretion. They are safe and effective. And in a survey sent to the CF community, about 29% of people are using insulin pumps. Unfortunately, few studies of pump therapy in CFRD exist. And like anything in CFRD or CF in particular, it's a rare disease. And so large randomized trials are going to be difficult. So most data is going to be observational or non-randomized. Here are some of the limitations of these current advanced diabetes technologies. AID systems cannot be used in persons with low total daily doses of insulin. So this is very, very important. So for example, the Tandem control system, you have to have a minimum of 12 units of insulin use per day. For the Omnipod 5, it's 6 units. For the Medtronic 780G system, it's 8 units. It's also important to note that these systems are designed for people with type 1 or autoimmune insulin or autoimmune diabetes. And so individuals with cystic fibrosis-related diabetes may get postprandial reactive hypoglycemia with these systems. So we need to keep that in mind as we adjust our settings. And then patient education is an absolute must. And then from a clinic flow standpoint, data management systems and IT licenses are actually required to review reports. So that's something you want to have in place before you start recommending these for patients. And then patient experience actually continues to be negative. Most concerns are around wearability, skin irritation, cost, and pain related to the device. So maybe not all patients are good candidates for device technology. So the incretin axis is another hormonal system that's thought to contribute to the development of cystic fibrosis-related diabetes. And so what about incretin hormones? So here's a little background on incretin hormones. So gastric inhibitory peptide, or GIP, and glucagon-like peptide 1, or GLP-1, are secreted from the L cells of our intestines. They're released in response to meal intake and other molecular stimuli, and they're rapidly metabolized and inactivated by dipeptyl peptidase 4, DDP4. Main actions are limiting postprandial glucose excursions, inhibition or slowing of gastric motility, and they're also CNS regulators of appetite. So to the left of the screen here, basically this just shows how GIP and GLP-1 exert their effects by binding to specific receptors. And then they increase intracellular cyclic AMP because it's a G protein coupled receptor. And that basically leads to insulin secretion, but in a glucose-dependent fashion. So this is a really nice study that highlights the evidence of incretin defects in people with cystic fibrosis-related diabetes. So figures A through F show basically concentrations on the y-axis. And figure A is glucose, figure B is insulin, figure C is insulin to glucose ratio, figure D is glucagon, figure E is GLP-1, and figure F is GIP. And then this is over time, which is on the x-axis. And then we have 3 comparators here: healthy subjects and CF patients with pancreatic exocrine insufficiency, either on enzymes or not on enzymes. And so what you'll see here is that what you'll see here is that figure A shows blood sugar is higher in CF than those without or healthy subjects. Insulin levels are actually kind of equivalent. However, insulin to glucose ratio was lower in CF patients than healthy subjects and not improved by enzyme supplementation. Glucagon concentrations are also fairly equivalent. GLP-1 is actually lower in CF patients than in healthy subjects, and that's completely reversed by enzymes. And then different than the GLP-1, GIP concentrations are lower, but actually are not increased in patients that are on enzymes, and remain lower in individuals with CF as a whole. So we have a few studies looking at DDP4 inhibitors in particular. So this is one study that's a randomized, double-blinded, placebo-controlled trial of 26 adults looking at sitagliptin, or a DDP4 inhibitor, in pancreatic insufficient persons with early CFRD. That trial was 6 months, and the effects on the incretin and islet cell function were measured in response to a mixed meal tolerance. After 6 months, persons who received sitagliptin had increased postprandial concentrations of intact GLP-1 and GIP, and partially restored insulin secretory dynamics and a modest enhancement in glucagon suppression. So the conclusion of this study is that DDP4 inhibitors, which increase the concentrations of active GIP and GLP-1, may represent an alternative therapeutic option for early CFRD. This is another study that basically looks at glucagon-like peptide receptor agonists, and this is a randomized placebo-controlled trial. It's a crossover design in actually 6 children and adolescents, and it evaluates the effect of exenatide, which is actually a short-acting glucagon-like peptide receptor agonist, in pancreatic insufficient CF patients with abnormal glucose tolerance. The subjects were studied for 2 days after an overnight fast in response to a pancake meal. And the outcomes here were area under the curve for blood sugar, insulin C-peptide, glucagon-like peptide, GIP, and they were all lower after exenatide. So the authors state exenatide may represent a potential treatment option in pancreatic insufficient CF patients with abnormal glucose tolerance. So I think in summary, these are attractive options due to lower treatment burden, as often they're a daily pill or once a week injection. They have a lower risk of hypoglycemia because, again, the hormone insulin is released in a glucose-dependent fashion. Sitagliptin, at least in this small study, was safe and effective. Less clear is the role of GLP-1, actually. And on top of that, I think unknown is the effective dose, and also should it be short versus long-acting GLP-1s. And then concerns remain about the potential of pancreatitis in our patient population, and also gastroparesis because of the slowed GI motility. So the last thing I'll say is also that if you start patients on these drugs, you should, particularly in young females, they need to be counseled on contraception because these drugs are not approved for pregnancy and they need to be stopped at least 8 weeks before conception. So in summary, I think more trials are warranted and are ongoing. So I think UPenn currently has their trial looking at GLP-1s in CF patients with diabetes. So lastly, I'd like us to consider pancreatic transplant. Transplant is an option. Both exocrine and endocrine dysfunction will be addressed by transplant. Typically, dual transplant is performed in combination with another organ, and so we see that most often with kidney currently. In CF, I would strongly consider in a population who's undergoing lung transplant for pulmonary disease or liver transplant for CF-related liver disease, because post-transplant diabetes develops less frequently in those who receive a pancreatic transplant versus just the solitary organ alone. And some authors suggest, or some sites suggest, that it's potentially underutilized. So in conclusion, insulin remains the gold standard of pharmacologic therapy. Advanced diabetes technologies, when coupled with education and follow-up, can improve the lives and health of people with cystic fibrosis-related diabetes. Interventions that raise GLP-1 and GIP might improve glycemia in CF, particularly in pancreatic insufficient persons. And pancreatic transplant is potentially underutilized in CFRD. So with that, I'm going to leave it open for Q&A. And I'll put this slide up because it's a really useful resource that comes out of University of Colorado from the Barbara Davis Center. And it's called the Panther Program, and it basically has information for clinicians and providers and the care team on automated insulin delivery systems, algorithms used by those closed-loop systems, and other healthcare team tools. So it's a great resource. Thank you.
All right, so we'll go ahead and do questions. As a reminder, please put those in the app or come up to the mic here and ask, but I'll start off with one from the app. So what initial pump settings or type of dosing do you typically use if you're starting an insulin naive patient with CF on insulin?
So I think it depends on, to answer this question, it was what dose of basal insulin do you put in the system, especially for an insulin naive patient. I think it depends on which system you're using. So if you're using some of the newer automated insulin delivery systems, they actually have automated basals. So you may actually only need to put in a total daily dose based on the patient's weight. And then over time, the system will learn. And then for some of the other automated insulin delivery systems and manual systems, essentially that is the systems work around the basal rates that you program into it. And so usually we'll use something weight-based if they haven't been on insulin previously, or if they have been on insulin previously, you'll take their total daily dose and you might use like 80% of that and then divide it out over the 24 hours. So all of these things are sort of your best guess. That's how insulin goes. And so I would say always, be more on the conservative side. And then what I do is see those patients pretty frequently and follow up to see if there's setting adjustments that are needed. Excellent question.
All right, I don't see anyone at the mic. So another one from the app. What is your experience or findings for patients on SGLT2 inhibitors?
So SGLT2 inhibitors work slightly different. I don't think there's a lot of data yet in cystic fibrosis-related diabetes, but essentially there's some effect in gut to delay absorption of glucose, but mostly in the kidney. And essentially you get sort of a diuresis and glucoseuria, and and they kind of create a state of ketosis. And so they might be helpful in maybe patients who are more overweight or have more of a type 2 phenotype. The issue with the SGLT2 inhibitors is they actually can cause something called euglycemic DKA, which is really dangerous. So basically normal blood sugars with ketoacidosis. And so I would caution people to maybe avoid using those unless somebody is already on insulin therapy so that they don't get the DKA. And I also usually counsel patients on, hey, if you have nausea, vomiting, aren't able to eat any food, you need to stop this drug and call the clinic right away.
Another question from the app. So in the post-modulator era, for patients who have had significant weight gain, would you also want to consider ruling out type 2 diabetes, and what testing would you do for that? This person said they've seen some higher A1C values recently in some of their new diagnoses.
I think this is a really tough question, or it's something our own clinic actually struggles with. There's a lot of heterogeneity in diabetes across without CF as well. And so CF patients, we also see that. So there may be people who are a little bit more insulin resistant for whatever reason. In obesity, it's not clear to me that they have the incretin deficiency. It may be more just that they have sufficient incretin, but the response is more blunted. And so I think when we think about use of these drugs in our patient population, you may be thinking about them a little differently for somebody with diabetes versus somebody who you're using it for in weight management specifically. And then the other thing would be for classification of type 2 diabetes. Sometimes what I'll do is I'll check actually a C-peptide level, and if it's quite robust, that would suggest that there is actually still a lot of insulin or pancreatic reserve, in which case I would tend to suggest, especially for an obese patient, maybe some agents that were more common in type 2 diabetes and maybe a little bit more weight loss promoting, for example.
Awesome. And last one, I think we have time for this one last question. So do you know what work, or if any work, is being done by the CF Foundation to advocate for coverage of CGMs or pumps for patients with CFRD? It's a challenge just because, especially with Medicare, CFRD is not a covered diagnosis.
Interesting. Yes, it is a challenge. And I think, I'm pretty new to the CF community. So at least from what I've heard, Compass will actually help with CGM coverage and also insulin pumps. So that may be one resource that you guys could think to use. At our center, we actually haven't had a lot of trouble getting coverage for devices. It's just a matter of determining Now, which benefit they have. Is it pharmacy benefit or is it device benefit? And if it's device benefit, then it usually has to go through a DME company. And we've been using, I was telling somebody else, a third-party platform called Parachute, and basically it's an online system that makes kind of ordering through device companies fairly easy. If there isn't coverage, I would suggest against it. These systems can be pretty expensive, on the orders of thousands of dollars, and so without coverage, I wouldn't recommend that somebody use one of these devices.
All right, thank you so much.
Thank you.
Thank you, Dr. Kaput. Our next speaker is Dr. Alex Philbrick, who is a clinical pharmacist in the specialty pharmacy at Northwestern, and he has been the clinical pharmacist in the Northwestern Adult Cystic Fibrosis Clinic for the past 7 years. He received the Cystic Fibrosis Foundation Pharmacist Grant in 2016, and in 2020 was accepted as a member of the multidisciplinary committee assembled by the Cystic Fibrosis Foundation to produce updated guidelines for cystic fibrosis liver disease, which were completed and accepted for publication this year. I will now turn it over to Dr. Philbrick, who will share updates on cystic fibrosis liver disease.
Thank you. I appreciate the invite to speak today. I'm Alex Philbrick. I'm a pharmacist on the adult CF care team at Northwestern, and today I'll be talking about updates in cystic fibrosis liver disease. Let's see. Okay. I have no conflicts to disclose related to this presentation. Our objectives today are to review the pathophysiology and epidemiology of hepatobiliary disease and cystic fibrosis, to present updated recommendations from the new cystic fibrosis liver disease guidelines that are relevant to pharmacy practice on the CF primary care teams, and to discuss the rationale for the updated recommendations. So let's start by discussing a little bit about the pathophysiology. CFTR is expressed in the biliary epithelium, and in CF, abnormal chloride transport leads to thickened, viscous bile in the small bile ducts, which leads to plugging, inflammation, and ultimately fibrosis. And this can cause several hepatobiliary pathologies, including cholelithiasis, hepatic steatosis, liver fibrosis, multilobar cirrhosis, portal hypertension, liver transplantation, and even liver-related death. While the terminology for cystic fibrosis liver disease has evolved, it's generally stratified into two categories: liver involvement, which is generally subclinical until the disease is more advanced, and severe disease, with the most clinically important manifestation being multilobar cirrhosis. This table illustrates the more common types of manifestations and the reported prevalence in the literature. It's the third leading cause of mortality, but accounts for only about 2 to 3% of the cases. However, the understanding of the landscape is changing, and the large, robust studies that allow for a more granular characterization of the disease have only been published recently. And many of these papers don't have a full accounting of the modulators, so there's still more to come. One such paper was the French CF modifier gene study. It was a large cohort of more than 3,000 pancreatic insufficient patients with CF born after 1985. Previously, CFLD was thought to manifest mainly in children, with the majority of cases of cirrhosis reported before age 18. But this group demonstrated that the incidence increases every year from birth 1 to 2%, and plateauing by age 25. Risk factors identified for CFLD were male sex, homozygous delta F508 genotype, and history of meconium ileus. Severe disease, which was defined as cirrhosis, portal hypertension, and varices, was rare before age 5 and reached 10% by age 30. This led the authors to conclude that adult onset CFLD may be underestimated. Guidelines for management of CFLD were last published in 1999. And since that time, research has advanced the understanding of pathogenesis, diagnosis, monitoring, and treatment. And so in 2020, the Cystic Fibrosis Foundation formed a multidisciplinary committee comprising pulmonologists, hepatologists, endocrinologists, pharmacists, nurses, dietitians, patients, and family of patients with CF to produce new consensus guidelines and recommendations with the goals of improving early diagnosis and care and improving morbidity and mortality. And in these guidelines, disease is stratified into advanced liver disease, which I'll refer to as advanced liver disease, and which is defined as having one or more of the following: nodular liver, stage 4 fibrosis, multilobar cirrhosis with or without portal hypertension, or non-cirrhotic portal hypertension, and CF hepatobiliary involvement, which I'll refer to as hepatobiliary involvement. They defined hepatobiliary involvement as having one or more of the following without any of the features of advanced disease. The full treatment algorithm, starting with screening in the primary setting and working down through management of advanced disease. Some of this would be done in the CF clinics, and some of this would be done by the specialists. There's a lot to unpack here. And so given the time allotted and the audience, which is primarily pharmacists located on the primary teams, I will try to focus on recommendations and developments that are relevant for our practice setting. Really good work has been done on screening, so let's start here, as this may likely become part of the registry and center reports. The Foundation recommends that AST, ALT, ALK-Phos, GGT, platelets, and total bilirubin be measured annually. This should be done at a time of clinical stability to detect hepatobiliary involvement. Early identification affects care through staging, regular monitoring, and treatments. Previous guidelines recommend more follow-up when the levels were 1.5 to 2 times the upper limit of normal. The current consensus is that this may contribute to delayed diagnosis, and the recommendation is to consider the patient to have hepatobiliary involvement if any abnormalities persist greater than 3 to 6 months. As liver involvement is characterized by persistent liver test abnormalities, calculation of liver fibrosis indices can provide a little more insight. They are calculated from routine labs and may be more specific than labs alone at detecting advanced disease or portal hypertension. The two with the most data in CF are the AST to platelet ratio, or APRI, and the GGT to platelet ratio, or GPR. The APR is the most studied in CF, and the GPR may be useful at detecting early hepatobiliary disease prior to significant hepatocyte injury. And they're easy to calculate. You take the patient's AST or GGT results, divide by the upper limit of normal for your institution, divide that number by the platelets, and multiply it by 100. There are some fibrosis thresholds established, but they're not widely accepted yet in CF. So at this point, the most important aspect is the trend over time. A physical exam can detect abnormalities that are clinically significant, such as enlarged liver or hepatomegaly, which is liver mass palpated below the mid-clavicular line. Hepatomegaly has been reported in patients, up to 30% of patients with CF, and the correlation between physical exam and advanced liver disease biopsy had 60% sensitivity and 44% specificity. And splenomegaly, this is a palpable spleen on abdominal exam, which has a stronger correlation with advanced liver disease, but is by no means diagnostic. And while the diagnostic capabilities are relatively low, they are easy to do on an annual basis and will provide useful information that can be incorporated into the bigger clinical picture. The third piece of recommended surveillance by the primary team is liver imaging via ultrasound. They are non-invasive, widely available, and relatively inexpensive, and they can be used to detect abnormalities not detected by labs or physical exam, such as heterogeneous parenchyma, which has been associated with an increased risk of developing advanced liver disease, and surface nodularity of the liver or portal hypertension, which are evidence of advanced liver disease. So let's spend a little bit of time on this, as it is an important new development. There are 4 basic ultrasound patterns that are associated with various outcomes in liver disease. Normal, which is normal hepatic echogenicity with no abnormalities noted. Homogeneous, which is diffusely increased parenchymal echogenicity compared to renal echogenicity. And heterogeneous, which is increased echogenicity that is diffusely patchy or limited to periportal regions. And nodular liver, which is heterogeneous echotexture of the liver parenchyma and nodularity of the liver contour. The prediction by ultrasound of the risk for hepatic cirrhosis, or PUSH study, is one of the most robust studies investigating the role of ultrasound in CF to date, which was designed to evaluate ultrasound as a tool for identifying children with CF at risk for developing advanced liver disease. There are so many interesting findings in the PUSH study that it can quickly become a rabbit hole, so my intention is to provide high-level review of some of the most important findings. Briefly, children aged 3 to 12 without cirrhosis or portal hypertension were enrolled. Ultrasound was performed at baseline and at years 2, 4, 6, and at year 8 or 9. And one theme that this study does an excellent job of demonstrating is the clinical significance of heterogeneous or nodular findings on ultrasound. For example, in patients that have heterogeneous findings, there is a significantly increase of developing nodular liver, which is advanced liver disease. PUSH identified a 9.5-fold increased risk compared to subjects with normal reading. And for patients who had heterogeneous findings that developed nodular liver, there was an increased rate of decline in platelets compared with heterogeneous patients that did not develop nodular liver. And there was a greater increase in APRI compared with those that did not develop nodular liver. And for patients who developed nodular liver, most did so between ages 5 and 13. The authors developed a model from study data that predicts about 10% of CF patients will develop nodular liver by age 18. Most will do so by age 15. And interestingly, normal findings confer a very low risk of developing nodular liver. It's also important to keep in mind that these were research ultrasounds, and each scan was reviewed by 3 to 4 radiologists trained for the study, and there had to be consensus. So it's not necessarily representative of real-world practice. And in terms of how lab trends over time can be suggestive of pathologic processes, going back to the heterogeneous groups, these graphs do a good job illustrating that the heterogeneous patients who developed nodular liver experienced a greater decrease in platelets and a greater increase in APRI over time than the heterogeneous patients that did not develop nodular liver, demonstrating the importance of following the trend over time. For patients who had nodular liver findings, they experienced a greater increase in spleen size and APRI and a greater decrease in platelets over time than matched normal subjects. And while these results are from pediatric patients from a well-controlled study design, they may not directly reflect real-world sensitivities and specificities of ultrasound as a tool in pediatric patients and also for adults. I think it's safe to say that the results do underscore the importance of heterogeneous pattern as a pathologic finding, indicating an ongoing destructive process in the liver. And it's for these reasons that the Foundation recommends ultrasound to assess liver and spleen in all patients with CF every 2 years, starting at age 3 until late adolescence. And for adults, the Foundation recommends a baseline ultrasound to detect abnormal patterns, but no specific recommendations can be made on the frequency of the follow-up scans. You know, if I had any PowerPoint skills, I would have included a Venn diagram slide here, something simple. Perhaps we can imagine this together, where one circle would have the labs with their sensitivities and specificities, and another circle would have the physical exam with its sensitivity and specificity, and the last would have the ultrasound with its sensitivity and specificity. And there would be a simple animation where the 3 circles come together and form a larger circle with a really cool name that we can agree on later. But for now, I'll refer to it as the screening triad. And there, beneath the cool name, there would be some new improved sensitivity and specificity, something that would increase our capture rate of patients with hepatobiliary disease and significantly enhance our ability to characterize and track progression of the disease. This would be a good slide to have here. With regard to the management of hepatobiliary involvement once it's detected, the guidelines do provide recommendations for follow-up on patients with abnormal findings, including an appropriate time for a GI or hepatology consult, which should perform a standardized workup of other causes of liver disease, but also for the primary team, and specifically for pharmacists. The Foundation recommends that patients with hepatobiliary involvement or advanced liver disease have a consultation with a CF pharmacist to identify high-risk medications and polypharmacy therapy modifications, and this should be done every 6 months. Polypharmacy is common, especially in advanced liver disease, where medication regimens can be complex. And studies have shown that involvement of pharmacists can improve outcomes, decrease medication errors, and improve safety. For patients with advanced liver disease, remember, these are patients that have either nodular liver, stage 4 fibrosis, multilobar cirrhosis, and non-cirrhotic portal hypertension. The Foundation recommends that physical exam as well as measuring all the labs be done every 6 months to detect progression of the disease. Elevations of AST, ALT, and GGT can indicate hepatocellular inflammation and cholestasis. elevated direct bilirubin can indicate significant hepatocellular destruction in advanced disease. And albumin and INR are indicators of liver synthetic function. The approval of the CFTR modulators has been an amazing development for people with eligible genotypes, leading to marked improvements in lung function, quality of life, weight gain, and nutritional status, exacerbations and hospitalizations, which brings up the question, what is their impact on the progression and development of CF hepatobiliary disease? Well, at this point, we simply don't know. Patients with liver disease were excluded from the clinical trials, and none of the liver disease-specific endpoints were measured or reported. And so there is insufficient evidence to make any kind of recommendation about the use of modulators to improve liver outcomes. And the foundation can't recommend for or against the use of modulators to improve outcomes. However, given that severe toxicity was reported very rarely, and that transaminase elevation of more than 3 times the upper limit of normal was reported in about 5% of subjects, very few required discontinuation, and treatment interruption with rechallenge was sufficient in most cases. This suggests a milder hepatotoxicity profile. Therefore, in the setting of hepatobiliary involvement, the committee recommends the use of modulators because the benefits outweigh the risks, and this is based on expert opinion. And for patients with advanced liver disease with portal hypertension but are still compensated, the committee cannot recommend for or against due to lack of evidence. And patients who are decompensated, which is defined as INR greater than 1.5, abnormal direct bilirubin, ascites, or encephalopathy, the committee recommends against the use of CFTR modulators. For patients who have received a liver transplant, the committee recommends that that modulators be started based on expert opinion. These patients still have CF or are at risk for disease progression after transplantation. And there are small case series documenting improvements in lung function, BMI, and quality of life. However, there is a complex interplay between transplanted organ, immunosuppression, and any medications that may alter concentration of immunosuppressant meds, as well as introduce a small amount of hepatotoxic risk. It's important to have close collaboration with the transplant team on when to initiate the modulator therapy, and to have pharmacist involvement to help identify and manage drug-drug interactions. Ursodeoxycholic acid, or ursodiol, a hydrophilic, non-toxic bile acid that was introduced as a therapy for CF liver disease with the rationale that it would help replace the toxic bile acids that accumulate due to abnormal bile viscosity, thereby providing cytoprotective anti-apoptotic effects on hepatocytes. And there have been several controlled trials, There have been several controlled trials and cohort studies that have shown improvements in liver enzymes, but they've had a shorter duration, between 6 months and 2 years. The problem is that there are no data that demonstrate the impact on the clinically relevant outcomes of advanced liver disease, nothing to demonstrate impact on progression to advanced liver disease or liver transplant. And so the foundation recommends against the routine use of ursodiol to prevent advanced liver disease, which is to say that ursodiol does not improve outcomes in long-term liver disease, so it should not be started with the intention of providing long-term benefits, as the data do not support it. And for patients who are already on ursodiol therapy, there are no data on discontinuation, and the recommendation is to use discretion when stopping. So evaluate your patients and question the rationale for adding it to the regimen. And if it's to improve liver outcomes only, then that would be a good candidate for discontinuation. So I'll plug the guidelines here. They've been accepted in hepatology and should be coming out hopefully soon, maybe December. And with that, I'll answer any questions.
All right, so I will take questions from the app first, unless anyone wants to come up and ask in person. First one is, how often would you recommend a hepatic ultrasound in patients on CFTR modulators who have kind of like chronically mild elevations in their LFTs?
So yeah, you know, with the 20-minute time allotment, we couldn't get into all the recommendations. There is a recommendation for patients who have been identified as having involvement to have follow-up ultrasounds every 2 years.
All right. And then in a post-liver transplant patient, what period of time post-transplant would you consider reinitiating a CFTR modulator or starting a new one?
Good question. I would say personally, after the induction of the immunosuppression, regimen is stabilized. The graft is, I think, probably most sensitive in the first month or so after transplantation. But there's also a benefits-risk conversation. So if a patient is very advanced disease and needs the modulator benefit, then it's not a hard recommendation. So we just need a very close monitoring and management.
Next question from the app. Do you have any tips or references for how to interpret a low albumin in someone who is also malnourished but at risk for liver disease?
Good question. So albumin is a measure of liver synthetic function, and I'm not sure how you would correct with the nutritional status. There are recommendations in the guidelines to have a dietitian involved with care, as well as, that would be kind of a specialist's hepatology management decision, I would think.
Yeah. And do you have any particular medications you would suggest we as pharmacists review or try and deprescribe for patients with liver disease in doing these every 6-month pharmacist reviews?
So in the back of my mind, I like to keep it simple. So I've got kind of a thermometer where you've got red, yellow, green. And in patients with advanced disease, they're going to be in the red category. Those are patients where you're going to want to be the most cautious, minimize your footprint, really consider anything that's got any kind of hepatotoxic risk and question the benefits and risks. And so it's really sort of an abstract juggling of risk management. So medications that are known to have hepatotoxic profiles, like some of the azoles that you would see, those are something you'd want to monitor closely, maybe institute frequent LFT monitoring.
Yeah, awesome. Thank you for coming up to the mic. Go ahead with your question.
Sure. Beechin Wu from Kaiser Permanente. I had a question about the screening and the guidelines in terms of, was there any discussion or recommendation for elastography?
Yes. Okay. So again, with 20 minutes, you can't get into all of it. So once you've identified on ultrasound that you've got involvement, then the next step would be elastography. And that's a recommendation. So transient wave or shear wave elastography.
Yeah, I bring this up just because in some of the other areas, such as screening for MASLD, formerly known as fatty liver, they're really prediction scores, and we go straight to the elastography because there could be subtle changes that we may not find on the ultrasound.
Exactly. So ultrasounds are good for advanced disease, but the involvement, staging progression of the involvement, you can measure that with the elastography.
Hi, I have a question. Is this working? Regarding patients with non-cirrhotic portal hypertension, were there any recommendations for medication to treat that? Because more and more patients are being diagnosed with non-cirrhotic portal hypertension.
So I wish I had more to talk about treatments. We don't have treatments for CFLD. We've got the modulators started early. I think there's going to be impact there. And then there's this robust pipeline for NASH/MASH drugs that's coming out. That may not help with the non-cirrhotic portal hypertension. So that's...
All right. Thank you so much.
Thank you.
Thank you. Thank you, Dr. Philbrick. Our next speaker is Justin Moss, who is a certified pharmacy technician that has been at Primary Children's Hospital in Salt Lake City, Utah for over 10 years and been in the Cystic Fibrosis Clinic for almost 5 years. He has been married for 14 years and has 4 children, which include an 11-year-old son, a 10-year-old twins, a boy and a girl, and a 9-year-old daughter. As a family, they like to play and watch sports together, especially football, as well as go bike riding and work on the yard. I will now turn it over to Justin, who will discuss the expansion of pharmacy services.
Thank you, everyone, for being here this morning. I don't know if any of you noticed on the app, but they actually had to do overflow for this session, so thank you, everyone, for being here. As Kelsey said, I am in Salt Lake City, Utah at Primary Children's Cystic Fibrosis Center and also the Primary Children's Hospital. I just want to say before I get started, a big thanks to Jeff Zobel. If it wasn't for him, I would not be in this space, nor would I be speaking here today. I worked right next to him for over 4 years, literally elbow to elbow, right into the thick of it. Our desks were next to each other. So thanks to him for this, for giving me the opportunity to be here for this. So before I get too emotional, let's go ahead and get into this. Oops. There we go. So I'm going to be speaking on the expansion of pharmacy services, mostly within technicians, but I'm sure for a lot of the pharmacists who may not have a technician, you might be able to steal some of these ideas as well. There are no disclosures for this presentation. So with that, let's go ahead and get right into it. So I just wanted to list some of the duties of a clinic-based pharmacy technician. Again, pharmacists as well. But let's start with the first one, PA submissions. It's our favorite, right? With a raise of hands, how many people actually do PA submissions in their clinics for their patients? Yeah, pretty much everyone, right? Right? Okay. So let's look at some other things, though, that we could look at. PA submissions, yeah, right, right. Also, PA submissions. Again, PA submissions. We can call insurance, though, but again, I think that probably goes with PA submissions as well. And of course, PA submissions. Now, again, with a raise of hands, how many of you feel like this is your job most days? Anyone? No? Couple? All right, all right. Follow-up question, how many of the technicians or pharmacists, like this is maybe actually 50% of their job? Anyone? Couple? Okay, okay. Not as many as I thought, so that's good. Maybe this will be a better presentation than I thought then. So let's look at some revised duties of a technician within clinic. Benefits investigation. This is a huge one for us. Anytime we get a new patient, whether it be a transfer patient, again, we're in pediatrics, a new diagnosis comes in, like this is one of the first things we ask. Do you have insurance? What is your insurance? If it's a new baby, have you added them to the insurance? Do you know when it's going to be active? Because let's be honest, if they don't have insurance in this country, they're not going to be able to get medication. So this is a huge, huge thing that we do and talk to the patients about, and making sure that they have coverage and that we know what that coverage is and what it looks like. And then following up with that, copay assistance. If it is a commercial plan, do they have the copay assistance available? Do you know all the programs available for all the different medications? Do you know the ins and outs of them? Do you know how to get these patients signed up for them? Do you know what they cover? Do you know what those out-of-pockets are going to look like? Do you know what the copays are going to look like? Like, if you need to be familiar with all these things for the copay assistance and what it covers and how those work, just to make sure that our patients are getting the medications they need at hopefully close to zero as possible. They have enough stuff to deal with. Trying to pay for their medication shouldn't be one of them. So if you're able to take on this role to help the patients, this is a huge, huge benefit you can provide to them. Following up with that is be the insurance champion. Do you know the state laws? Do you know the insurances that you have in your state? Do you know the ins and outs of most of the plans that you see and what it looks like and how to get those, going back to the prior authorizations, to get medications covered? So kind of be that champion for your patients. Know what you can do to help them with the insurance and with those insurance questions. Another one, medication history or the med reconciliation, kind of depending on what your institution calls it, what the software calls it, what your state allows. One of the things that I do is I actually see the patients day in, day out. I'm full FT. I'm in the clinic 40 hours a week. I probably see every patient every day most of the time. And one of the things we do is go through their medications. Do they know what they're taking? Do they know what they're called? Do they know how much they're taking? What's their adherence look like? And just being able to answer any of those questions that they may have regarding medications. This is a great opportunity to, one, get to know your patients, get to know what their adherence looks like, and be able to answer any questions right there on the spot. If they have any regarding how to either take it or if they're having issues, you can find a lot out when you're asking them what they're taking and how they're taking it. Be the main contact for your specialty, with the specialty concierge. If none of you know what that is, I highly recommend to reach out to your specialty pharmacies. Ask, do you have a CF specific person? Or is there a department that does this? Whether some of them are under pulmonary and they just have a large group, or that may be CF specific. Our next speaker I've been in contact with since the day I started with the specialty pharmacy at CVS. She's been a great asset trying to get help with patients' insurance questions, with needing to do PA renewals, copay assistance, whatever it may be. These programs are amazing. It can save you a ton of time having to call in and push 50 times or screaming into the phone, representative, representative, no, representative. So if you do not have those, please reach out to your specialty pharmacies and ask. Get that signed up. Make sure you have these contacts, whether it's a email or a direct phone number, just to save your guys' time. Also, refill requests. We try to make sure that we stay up to date when we see patients, but let's be honest, sometimes patients don't show up all the time, or maybe there's some issues. So taking care of those refill requests, take it away from your nurses, take it away from whoever may be handling it. Again, this is a great opportunity if you have those concierge. If they email you directly and say, hey, we need a refill for patient XY, and this is the medication we need, it saves on phone calls. It saves on having to go through them faxing the information and trying to go through the nurse line or whatever it may be. Saves a ton of time, and then it also saves time with your patients because now they don't have to wait for the request to be sent and then sent back and all that fun stuff. So actually can help with adherence as well. Medication refill. So one of the benefits that I have is actually working with our outpatient pharmacy at Primary Children's, where a program that Jeff developed when I first started was being able to do medication refills through our outpatient pharmacy and act as a pseudo specialty pharmacy, and being able to fill medications and mail them out to the patients directly. Depending on the insurance contracts, depending on what they consider specialty or non-specialty, we try to fill as much as we can. I have about 70 patients that I fill for. About 30 of those I'm able to fill Pulmozyme for. For modulators, they have to go to specialty pharmacies, and obviously with some of the inhaled antibiotics as well. But it's a great benefit if you're able to do that, just to be able to set those refills up and get them sent out to the patients. It saves them on a lot of time, and maybe instead of having 8 different pharmacies, they now have 2 or 3. So again, saves time for the patients, plus it gives you a little more insight on how the insurances run and making sure that, again, they have those 0 copays. Another thing, pre-clinicking is what we like to call it, just basically a week in advance, looking through what your patients for the next week, getting an idea of who you're seeing and maybe any type of issues or questions that you may have for them. So some of the things that I do is looking at the refill history, reaching out to the concierge, saying, hey, when did the patient fill last? Any issues? Do they need PAs? Any of that stuff, you can find all this stuff out before the patient even shows up. Again, going through refills needed, save time on having to get those calls. tracking labs or eye exams. You can look into all that so you know exactly what you're doing before they get there. And then just kind of looking at any known issues. Maybe they're not feeling something. You can ask them if there's an issue, is there an insurance issue, just anything that you might be able to kind of hopefully kind of figure out before the patient's actually there. So looking at that list, that's a pretty robust list, I think, of things that you could do. But I also have another one. Quality improvement. I don't know how many of our technicians or pharmacists get a chance to work with their quality improvement group. At Primary Children's, we have a very robust quality improvement, not just within the hospital, but within our CF clinic. And I've been fortunate enough for the last 4 years or so to be able to be on that team and actually do things that's a little bit outside of my comfort zone, being able to work hand in hand with the dietitians, with the providers, with respiratory therapists, working on projects to be able to improve our patients' clinic times, issues, whatever it may be. So if you have the opportunity to be able to join either a team or just even a subcommittee within your organization, I would highly recommend it. It's such a great benefit, not just for our patients, but for ourselves. Working on transition. Since we are a pediatric facility, we do work with the adult team, so it's kind of nice to be able to work on that transition, whether it be to get the patient ready to be transitioned or to provide information for the team as they transition. It's a big opportunity to make sure like your patients know their medications. Do they know what insurance is? Do they know how that works? Like if you're able to kind of take that role, maybe not for full transition, but at least for the pharmacy piece for our patients, and be able to take that away from the nurses or whomever it may be, just to provide them a little more time. And then again, with our specialty is pharmacy, like let's make sure that our patients know where they're getting their medications. Another one we do is we look at immunization records just to kind of make sure to see where our patients are at. Are they up to date? Are they vaccinating? Are they up to date on all their immunizations? If they have questions about it, we can use this as an opportunity to be able to talk to them about it. And not only that, we're able to actually provide immunizations through our outpatient pharmacy and be able to give the immunizations in clinic when we see our patients. This has been a huge benefit for our patients. I've got a slide on it a little bit later, and just kind of showing some of the things that we've been able to do for our patients. And then another one is pre-visit planning. Our institution, we send out an email about a week before the patient comes in and just has a list of questions and things. And it's kind of nice because then if they have any questions that's pharmacy related, the nurses just send it directly to us. So we know ahead of time what we're kind of getting into once we get into the room. Another thing would just be adherence checks. In the past, we all have patients that maybe aren't the best at taking some of their medications, but what if you just talk to them and say, hey, what if I called you in a week? Or what if I called you in a month just to see how you're doing? Just to kind of give a follow-up, and then kind of gives them a little bit of knowing like, oh yeah, I'm going to be called by myself, and asking if they're, up to date on everything. Another one, again, just lab work and tracking, setting up reminders, whatever it may be, for the patients. And then just follow up post-hospitalization calls. We do that a little bit. It's more just to make sure that if they're starting a new medication, just making sure they got it after they got out of the hospital, if they're not able to get it while in the hospital. It's a huge benefit just to be able to give a quick call like a week later, just say, hey, did you get this medication? Have you been able to take it? How often are you taking it? And just to make sure you have any questions. Some of you have probably seen this slide before. So this is our little diagram for our integrated pharmacy team at Primary Children's. Just kind of going through it. I won't go into too big a detail, but just kind of showing that flow of it's being patient coming in, being seen, we go through and just check their medications, making sure everything's up to date, making sure everything's good. If we're starting new medication, doing that benefits check, and then where does the medication go? Does it go to our Intermountain Specialty Pharmacy, which is the specialty pharmacy portion of our organization? Can we fill that at Primary Children's, or does it need to go to a specialty pharmacy? Such as kind of the quick diagram of that flow chart of what it is. On this next slide, I just want to kind of show you what the preclinicing kind of looks like. So here we have Bob Fett. He is the cousin of a very known bounty hunter. So we're just looking at his refills. Looks like he's been filling his medication. So when I take a look at this, I kind of more looking at just for like enzymes, if they're making sure they're filling their asthma medication and stuff like that. I'm not going to worry about every single thing, but kind of just the ones that we really look at. And then if they're filling their specialty medications, what refills they're needing. Did they get an eye exam? If that's something we're tracking, when was the last one we have on record? Do they need to get a new one? When did they start their modulator therapy? I have a grant, so we know exactly when it expires. In this case, it's getting ready to expire. I've set myself a reminder saying, hey, I need to renew this, and then just kind of knowing when the next one is, and then if there's any vaccines that they're due for. So if I do all that pre-work, I'm not doing it the day they're coming in, and I already know, so I can walk in and say, hey, did you get an eye exam? You're due for these these immunizations. Do you want to go ahead and take care of those while you're here today? I talked about how I actually fill for patients through our pharmacy. This is just kind of a quick thing of how I kind of manage that, just kind of showing like their date of birth, the name, who to contact. Again, we're pediatric, so I'm calling the parents, just having that information, and then just kind of giving myself some notes of what they're filling, when they filled it. Were they picking it up at the pharmacy? Were I mailing it to them? Were they getting it at discharge? Are they coming into clinic next week and they want to pick it up? Just so I know what and where they're getting the medications before I call them to set those up. And then this is our immunization care process model. We actually published on that last year, but I just wanted to kind of show again for all of you here today just kind of what that looks like. It's kind of a big flow chart, but really it's not too bad when you really kind of get into it. It's just, do they need vaccinations? What are they due for? Do we have it? How do we administer it? Who can give it, et cetera. And then this is just kind of the total that we've been able to give over the last 2 years. We were able to give 781 vaccines to our patients over the last 2 years. Most of those were the PPSV23 and a bunch of COVID vaccines. And then for like HPV, MCV, we get a little bit of flu and different things. Most of those are just to play catch up. We don't want to take on the role of being the PCP for our patients, but if they are overdue and we're able to get them and they're in clinic, why not try to offer that to them to get these patients caught up? So in conclusion, I just love this little thing about being a pharmacy technician. I think it's kind of funny, just the fact of all the different things. But I just want to say thanks for the opportunity to speak to you guys today. And I guess with that, we'll go ahead and open up to questions.
Perfect. All right, we'll go with our first question from the app. So do you know what your response rate is for patients actually answering a pre-clinic survey or questionnaire?
I do, because I'm on the QI team that's monitoring that. And we presented on it, and I talked on it yesterday. So before we started our QI project, it was about 9%. And looking into it, we found that it wasn't being sent very well. And we changed a few things, and we're now up to close to 40% response rate. But then looking into the data a little bit more, the way we're able to track it, we found out that there's about 70 or so % of people that are actually getting it and opening it. So they're not replying back, but they actually become more prepared when they see those pre-visit planning emails. So they come in, maybe they didn't respond, but right when you walk in, hey, I have question XYZ, or they know they're getting labs, whatever it may be. So it's actually improved our clinic time a little bit as well.
That's awesome.
Yeah. Can you hear me okay?
Yep.
All right. Thank you. I actually find the pharmacy tech to be the most helpful from a clinician standpoint, so appreciate it. What do you do around, January's coming up, and for at least diabetes patients in particular, the insurance companies decide to change their formularies every year. So how do you handle the formulary changes and help reduce anxiety for patients around that? Thanks.
A lot of Red Bull. Sleepless nights, no. It is tough, especially going into January. I mean, I'll be honest, I usually don't see a lot of patients during the month of January just because I'm usually fielding calls, changing prescriptions and different things like that. It's nice with our patients, they know they can just reach out. They can reach out to the pharmacy team or just send a message through our secure messaging software to be able to say, hey, this is what's changing. Can you help me with it? And the nice thing being able to, I can run everything in real time. So even if I'm not filling for them, as long as I have that insurance information, I can run those test claims. I know exactly which strips they need, which insulin it needs, and then can go and work with our endo team to be able to get those switched. So it's actually not too bad when it comes to that. But having the benefit of being able to run those in real time, those test claims is huge.
I would say also a reminder to the patients toward the end of the year that at the first hint of any issues that they're having getting things from the pharmacy or that something might be switched, to remind them, call us right away. That way we can have a little extra time, not when they're out of medication. So, let's see. One thing I was going to ask is, so I think one of the really cool things about our growing pharmacy community in CF is that everyone in the CF world realizes how much we need our pharmacy technicians. But you talked about doing QI and you're here presenting. So for newer pharmacy technicians, do you have suggestions of how they can get comfortable getting involved in stuff like that when that might be a really new area to them?
Yeah. So I actually, when I started QI, it was because I went on the mentor program and went to my site visit and realized that the technician there was doing QI and they were doing this really cool project. And so I brought it back to our clinic director and just said, hey, this is a cool thing they're doing. I thought I would just pass this on. And he goes, great, why don't you present it to the team? And I went, excuse me? What? I can do this? What are you talking about? I came from a retail background. So it does take a little bit to kind of get used to, but I think just if you go into it with an open mind and just not be scared about maybe the mental block that I think some technicians have, just saying, I'm just a technician, and really just trying to work at the top of your license, and hopefully you have a really good pharmacist that will push you and kind of just sky's the limit. Whatever you're comfortable doing, let's figure it out. Let's try to do it. But because of that, like I said, I went and presented it and they thought it was a great idea. And then they're like, why don't you join the team? And so I did. And it took a little while to kind of figure it out, especially kind of going through COVID and everything was virtual. So there was a little bit of I was kind of behind up with the rest of the QI team, but it was a great opportunity. And like I said, still on it. I serve on 2 different subcommittees within our QI group. Like I said, we did a huge project and presented on it yesterday. So any of those opportunities, you have a chance, take it. If you have the opportunity, take it. You're not going to lose out on not trying.
Awesome. And there's 2 good questions in the app. So I'm going to kind of combine them because they're a little bit similar. How do you balance your pre-clinic planning with all of your clinic duties, immunizations, everything that you're doing? And then how do you kind of make sure that doesn't overlap some of the other disciplines and work people are doing in your clinic?
I would say make sure you're not stepping on anyone's toes. Make sure that you are working with the disciplines. We have a really good group at our site that we kind of all know what each other's doing. And if you're able to kind of take on some of that or be able to maybe pass some of that off to give nurses time back, to be able to do whatever, helping dietitians or whatever it may be. But what it really comes down to is patient care. So if the patient care is lacking because of other things, then maybe pull back. There's been times where I'm like, I'm sorry, I can't work on this QI project this month. I have way too much stuff going on for this because patient care comes first. So I would definitely say put that at the top and then just kind of figure out your clinic flow from there and see what works. Not everything's going to work. There's some weeks that I don't get the pre-clinicing done as thorough just because there's so much other stuff to do. It's kind of nice. We have a set clinic schedule. So usually like Monday, Wednesday, and Friday afternoons, we don't have clinic. Thursdays and Tuesdays, we have full clinic all day from 8 a.m. till sometimes 6 p.m. in the afternoon. So on those days, maybe I'm not working on some of that other stuff because it's about the patient care.
Awesome. All right. Thank you so much.
Thanks.
Thank you, Justin. So our final speaker today is Tanisha Gordon, who is a cystic fibrosis practice liaison and practice liaison supervisor of pulmonary arterial hypertension at CVS Specialty Pharmacy. I will now turn it over to Tanisha to talk about specialty pharmacy services.
Thank you. All righty. Before I begin, I know we've talked about Jeff a lot, but I will have to tell everyone. So before I became a practice liaison, I actually got the role of practice liaison because of Jeff. He actually called my pharmacy and pretty much blasted specialty out about the lack of for cystic fibrosis. And they quickly created a PO program for CF. So that's how my role came about many years ago. I just have to let you know, but definitely a great mentor and definitely a great partner along the years. He taught me a lot, so I have to do that disclaimer. All righty. All righty. All right. So as my role as a practice liaison with specialty, there's one direct number for all your answers, for all your CF prescription-related questions. Proactive patient onboarding, support and updates on initial therapy shipments, patient reports, prior authorization, refills, all based on your office preference. So you as a provider, you as a clinic, you as a pharmacy technician, just like Justin stated with his information, concierge service, if you need that service, if you need just that one provider contact, I'm your person. Call the pharmacy, get that one person that can give you that one streamline, however you want that information, all based on your office preference. Nursing support. Insurance and appeals coordination as well. Financial assistance and prior authorization handled through a single point of contact. Appeals and expertise when a treatment is denied by the patient's health plan. Patient's onboarding. Coordinating between the pharmacy and the medical benefits for a quick onboarding service. I'm not sure so many times, you have to call that phone number and say, hey, what is going on? I'm that person, that one single point of contact. Seamless connection to patient-centered care. Pharmacy-led care team that provides high-touch therapy support to our patients for improved adherence and safety. Responsibilities of a practice liaison is to act as that single point of contact for the designated doctor's office and treatment centers. Practice liaisons will coordinate with sales, nursing, operations to manage the patient's needs of the designated offices. Practice liaisons triage issues as appropriate to the departments and update the designated offices accordingly. Practice liaisons are responsible for maintaining a positive relationship with accounts. Practice liaisons may oversee sending reporting to accounts as needed based on the office and your account's preference. copays, out-of-pocket costs after insurance. So I really want to focus on this. This is really near and dear to me. I want to talk about our cost accumulator for our patients. I don't know in your centers, in your clinics, how many times patients have come to you and said, hey, you know, I thought we met our deductibles. You know, we've paid so much, or, you know, we've paid so much already, or, hey, I thought the copays covered this. You know, the Pomazine copay card covered so much, or this particular program covered so much, and now it's November, or now it's October, and, you know, we don't have any more left on our copay, but they still say we owe $5,000 or $6,000. Why is that? Copay cost accumulators, the deductible. Total out-of-pocket amounts for members before benefit plan coverage will take effect. Amount varies by plan. Copay covered by copay assistance will not count towards deductibles. Now, of course, I will say that's not with all plans, but a lot of plans have adapted that new rule. Out-of-pocket maximum money out-of-pocket for members in a member's plan. Amounts, of course, vary by plan. Services are 100% covered, then once met. I want to talk about that just one more time. I'm not sure how many centers, how many clinics have experienced that with patients. We hear it a lot with the pharmacy. A lot of plans have adapted this rule. I encourage everyone to please educate your patients, speak with the families. When there are different copays that will cover the medication, but it does not subtract from patients at the actual deductible that the families have. So if they cover, the copay cards have covered all year a maximum of $8,000 or $10,000, but it has still not taken away from the patient's copay, it has not taken away from the actual deductible of the plan. And then if the family finds themselves come October or November still owing at $5,000 or $7,000 or whatever the deductible is, and they're still due for that amount, please make sure that we educate our families to let them know that. And also, please make sure that they also speak with their insurance companies about this as well. This is something that's near and dear. I actually had the opportunity to visit Capitol Hill back in September to speak with the Senate as well about this. We need to make sure we're speaking with the families. We need to make sure we're educating our families to make sure when they're picking an insurance plan, when they're picking a deductible plan, that they really pick the best plan for their family, because a lot of the copays are not factored into that. When you're taking away from those copay cards, they do not take away from the actual deductible of the patient's plan. Okay, I'll take questions in here.
Right. All right, I'm just checking to see if we have any from the app. So one here is, sometimes it feels like some of the bigger specialty pharmacies, national pharmacies, have a silo type of feel where one department has to hand off things to another because it's out of their department scope. So this person said they use an in-house specialty pharmacy in their health system that can get test claims run in just a few minutes. So can you describe the general prescription intake process and how CVS is trying to make those departments more smooth and integrated?
Yes. So I could explain for the CF world. So within the CF world, if you send in a prescription within CF, it goes into one specific area. We go ahead and run the claim. If we're able to fill the RX, it goes through the benefits verification department. Within the benefits verification department, it takes 24 to 48 hours for the benefits to go ahead and process. Within the benefits process, if the claim runs smoothly, then the next thing is for the department, for the CF department to go ahead and call the patient, and that should be within 3 business days. That is if it runs smoothly. If there's something that doesn't go right on the roadmap from there, that's when the provider will have to be called. If you have a practice liaison, which is what I spoke about today, it goes a little smoother than that. So if you have a practice liaison, generally you would send that information over to your practice liaison. Whichever your preferred communication is, your practice liaison will let you know, hey, I have the RX or have that information. You'd work with them, whether you would have them to work on the prior authorization or you send a prior authorization approved. If it's already approved, we can get that medication out generally the same day or the very next day, pending that we can speak with the patient about. Hope that answers your question.
Another question is, how does a clinic get a practice liaison or find out who their liaison is for CVS?
So you can get a practice liaison by calling CVS Specialty direct, asking for the cystic fibrosis department, and you can request a practice liaison. Or you can get in contact same way, call CVS Specialty and ask for a SPOC, call CVS Specialty, ask for the CF department, and ask for sales. And you can also request a practice liaison as well. They ask you a few qualifying questions about how many patients does your center have, or how many RXs or how many referrals will come through. Based on that, you can either, they'll refer you to a practice liaison or they'll refer you to a SPOC. And what a SPOC is a single point of contact as well, and that's usually a pharmacy technician that will handle a specific group for your patients direct. So they'll usually, that SPOC will handle your patients only.
Cool. And is there a CF specific phone number for CVS Specialty, or is it just that the clinic should contact their practice liaison? Is there just a general CF number for people to call?
Yes, there is a general number for CF patients only. It is. I don't have it, I don't know it by heart, but there is a general number for CF patients only. And then just FYI, there is a general department for CVS Specialty that only a general department handles CF patients only. So when your patients call CVS Specialty, they shouldn't be handled by any pharmacy technician there. There is a specific department, and when it pops up, it says cystic fibrosis patient. Please do not handle. And it pops up on the screen, and it gives a little extension. So a lot of times, if your patient calls and they, for some reason, end up in a different department, someone will say, excuse me just a moment, let me transfer you. And that's because it is a center of excellence therapy, and only a certain department can handle those patients.
Jeff, go ahead.
Great job, Tanisa. Don't be, she knows her stuff. If you have any issues with CVS, get a hold of her. Or Nina, there's another one that works.
Yes,
they do a great job. My extreme example was Christmas Eve, a Sunday, patient ran out of Zenpep. I called Tanisa and she got it taken care of within 24 hours on Christmas Day. So you get a single point of contact. She's not just a single point of contact. She cares and she knows her stuff and she knows what's Cure Found or CF. Tanisa is that person at CVS. So thank you for all you do.
Thank you.
And I actually do want to add something. I actually do have the special phone number to reach the CF department for the CVS specialty team. So if you would like to get your phone out or write down this number.
Thank you, Cassie.
It is 866-845-6790. Again, it's 866-845-6790. It'll save you a lot of time on the phone.
Yes, reaches the CF department direct.
I'm not sure how this shows up in the app, but I also put that phone number in the response to the question, so you might be able to find that through your question and answer section in the NACFC app.
Okay.
Let's see. Do you have a recommendation on when is a good time to start going over benefits guides for families, as open enrollment is kind of right now this time of the year and only lasts usually a couple weeks?
Absolutely. So this is the time now. So families are getting that information in from their insurance companies right now. It is a great time to go over. It's a great time for families to call the plan direct, not just read it. It's time for them right now to call the plan direct. Or if you're helping the family, get on the phone with them, take down the name. Take down the name of who you spoke to, especially for those cost accumulators. Ask them, hey, if I'm getting a foundation to help, is that taken away from my deductible plan? Get that information, and get names specific. We want to make sure that we get names of the representatives as well that we're speaking to. Really, really important so we can refer back to who we spoke to.
Yes.
Well, thank you very much for your discussion. I think this is really good detail that we all need to know. I have two quick questions. One is a pharmacy liaison a standardized term across different specialty pharmacies as a position so that we are using the same language and seeking the correct thing, as we call, let's say, outside of CVS, might be somewhere else? That's one. And then the second is, and again, I know that we need people in all these different aspects of delivering healthcare services to our patients, including pharmaceutical companies and our specialty pharmacies and our clinic-based, healthcare professionals and so on. So everybody has a role, and I get that. My wonder is, as these cost accumulators become more and more common, and I'm wondering that they will, can someone, because I certainly don't know, what is the benefit of a copay card anymore? If it defers, it seems to me like it defers a payment out of a pocket of a family until maybe the end of the year when something else might happen in that family, unrelated, let's say, to CF, and now that family owes $8,000 because, or whatever the number is, because they haven't been paying it along the way. Like, what's the benefit? And I think these copay cards, if I'm correct or not, come from the manufacturers. So, drug company A, drug company B, drug company C. What's the benefit of a copay card anymore?
So great questions. One, different pharmacies call them different names. I've heard them called practice liaisons, concierge, SPOCs. Those are the three top names that ring a bell to me. Different pharmacies, different thing, but definitely practice liaison, concierge, and SPOCs. I've heard that. Single points of contacts. Those are the ones that I ring a bell. And the benefits of the copay cards for all these years have been great. They help families. They give back. The cost of medications are very expensive, but we have to look at two factors. We have to continue to rally, our state and our government to say, hey, let's keep these insurance companies separate. Why are insurance companies concerned with who's helping us? And let's bring it to plain terms. It would be almost as if when we go to grandma's house and grandma hands us $20 or $30 like they did on Sunday, well, if she hands us the $20 or $30, why does Blue Cross Blue Shield, and I'm just throwing a name out there, I shouldn't say a name, but why would they care, right? Why would they care? Are they gonna charge us an extra $30 next month? No, that's not how it works. So, like I said, I had an opportunity to visit Capitol Hill, and with the Senate, and it was very, very well received with the senators that we spoke with on all sides. And it was saying, hey, take it to the insurance companies. It shouldn't matter if we're getting help with copays. And this was to rally for all patients. These are two separate matters. If we're getting help with that, it doesn't matter who's helping us. Doesn't matter if it's a copay company, if it's a mom or dad, doesn't matter who's helping us pay for the medication. That has nothing to do with our deductible. So the copay cards are great. The foundations that's helping us are great. Has nothing to do with who's helping us. Those are two separate matters. So we have to continue to press with the insurance companies and continue to be an advocate for our patients to say, you cannot mix the two together. That's our voice. You can't mix the two together.
I guess not really a question, but a comment. So, yeah, it's a tough issue. Copay accumulators, right? It affects all of us. There's 13 states right now that have enacted legislation on that. There was a recent ruling in Washington, I think, in the district, where a district court actually, they brought this case to a district court. The district court actually ruled that copay accumulators are not legal. That is that's a big case, and if that rolls forward, that sets precedent. That's the first one that I know of in the U.S. that's actually done that, because then that can potentially roll over if the federal government takes action on that. What we've done in the state of Utah, and I've burned a lot of energy and time on this, started in 2018 to bring a copay accumulator bill forward in Utah, and we got destroyed the first year, so we didn't. And we brought it back last year, didn't get quite as destroyed, and right now we're working in the interim session with, I got a senator and a representative on crafting some legislation. So hopefully third time's a charm. Hopefully they don't strike out on the third time. But my point to this is you can sit back and play defense if you want and just have stuff happen to you, or you can choose to try and go on offense. So we tried to go on offense in our state, and again, haven't been successful for the last couple of sessions, but we're not going to stop trying, because at the end of the day, who does it affect? It's the patients and their families, right?
Our patients.
When I'm up there on our Capitol Hill, that's what I'm thinking about. And actually, I've brought patients with me to testify and that sort of stuff too. So anyway, just
absolutely. Absolutely.
Tough fight.
We have to fight for our patients, and we have to educate our patients, everyone. Make sure they know what's going on, because they don't know. So please make sure that we're talking and we're speaking with our patients about this.
So when you identify, or the medication is billed at the pharmacy level, and you identify that the patient has a unaffordable copay, regardless of what it is, what services can the CVS group offer, or can you provide in terms of getting them connected with financial resources, or what is your process like for that?
So this time of year, it's happening more so. The copay cards have now run out because they're at the end of their funding, and now we see this huge this cost accumulator. Now they have this deductible that hasn't been met. We have a program called RCC, which is a program that CVS Specialty has, and that's when they have different programs that will have different types of grants for patients that will help them cover the medication. And this again is if they qualify. So there's a lot of different factors there as well. That's why we fight so hard for getting these bills passed if they qualify. Payment plans, if they are able, if they want to join a payment plan, we also have a payment plan as well that patients can join for the medication as well if they are willing to do that.
Yes. Yeah. Anything else?
All right. Thank you very much, everyone.
Thank you, Tanisha. And I want to thank you all for your time and insight today. I hope you enjoyed our discussions, and I want to give a special thank you to our presenters, and a special thank you to my co-chair, Hillary, who was a pleasure to work with over the past several months. This now concludes our session, and I hope you have a great rest of NACFC. Thank you for being here.
Thank you.